and being a part of this wonderful academic journey. And we would like to start our program first by a welcome note from our President, Sir, Dr. Srinivas, Sir.
Srinivas sir.
Hello.
Sir. Hedi sir.
So, good evening, everyone. So, I have to welcome our teacher, Vishwanath. He is our Bangalore branch, past EC member, good friend of me. Also, he worked with me in Kim's Hospital, actually. So, very, very thankful for him to coming here and taking class for you people. And I'm extremely thankful to our Madhusudan Karignur, past president. He is the man who is behind this program. He is doing quite hard work here. I'm very, very thankful to him. Next, Subrata is there. And Dr. Krupa, Krupa is there. So definitely this type of programs, you will expect little more to come. And I wish all this program all the best. And hope everyone will utilize this program. Thank you, one and all. Thank you, Madhu, again. Thank you, Vishwanath. Thank you, Vishwanath, again. So thank you. Bye. Keep in touch. Bye.
Yeah.
Thank you. Go ahead, Madhu.
Yes, sir. Krupa, carry on.
Thank you so much, sir. Now I would like to call upon Humpy, our host for today, to start the official program.
Good evening, everyone who has joined us today. I'm Humpy Sadashiv, State Co-Convener. I would like to welcome all our dignitaries that are there today. Our past President, Dr. Madhusudan Sir, IMA State President, Dr. Srinivasa Sir, State Chairman, Dr. Subrata Ma'am, Honorable State Secretary, Dr. Shakuntala Ma'am, IMA MSN State Co-Coordinator, Dr. Mithun, Chairman Academic Subcommittee, Dr. Shantala, IMA MSN State Convener, Krupa. Today, our discussant for the evening is Dr. Vishwanath Krishnamurthy, sir. He is a professor of medicine from MS Ramaiah, Bangalore. And our presenter today is Swati from BIMS, Bidar, for today's clinical presentation series on the topic CNS. Before we continue with our case, I would like to invite Krupa for the IMA prayer.
Let us start with our IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
I would like to request the presenter, Swati, to turn on her audio and video.
Yeah, Krupa.
Yes, sir. Our presenter for today is Swati, final year MBBS student from BRIMS, Bidar. We welcome you, Swati.
Thank you. Good evening, everyone. Today I am presenting a case on hemiparesis.
I request Dr. Madhusudan sir to once introduce our discussant.
Yeah. I welcome on behalf of IMA Karnataka State Branch all the students and faculty for this case presentation series. This is the sixth case presentation that we are having in this academic year. And on behalf of IMA Karnataka State Branch and also IMA Medical Students Network, I would like to welcome today's discussant, Dr. Vishwanath, who has got a very vast experience in undergraduate students teaching. He is from MS Ramaiah Medical College, is professor and unit chief. And he was more than happy to be part of this. And he was very glad in his initial remarks that this is one of the very good forum for the students to come out with acquiring knowledge and case presentations. I welcome you, sir, for this case discussion. Definitely it goes a long way in guiding our undergraduate students, where the clinical examination is getting lost in the era of investigations and a fast-moving life. Thank you, sir. Thank you. Welcome once
Thank
again.
you. Thank you. Swati, you can start, I think.
Okay, sir.
Yeah.
Here is 54-year male Rajappa, farmer by occupation, resident of Chimkod. Informant is his son and he is reliable. Handedness is right-handedness. Date of examination is 28/12/2023. Chief complaints. Patient came with the complaints of weakness in the left upper and lower limb since 10 days, deviation of angle of mouth to the right side since 10 days, slurring of speech since 10 days. History of present illness. Patient was apparently alright 10 days back. Then patient went to the sleep at 10 p.m. and woke up at the 6 a.m. the next day. And patients experienced weakness in the right upper limb and lower limb. So that is left upper limb and lower limb. He was unable to hold a glass of water. He had difficulty in squatting and gripping his slippers. Patients presents with deviation of angle of mouth to the right side while speaking and showing his teeth since 10 days, which was sudden in onset associated with drooling of saliva. He had difficulty in chewing the foods. Patient has no difficulty in closing his eyes. Patient has slurring of speech since 10 days, which is sudden in onset. He was able to understand the commands and use appropriate words while talking. He was able to repeat the sentences, but fluency is decreased. Patient was brought to the brims on the same day evening. Negative history. No history of headache, nausea, vomiting. No history of head or spine trauma. No history of loss of consciousness. No history of transient loss of the vision. There is no history of altered sensorium and behavioral abnormality. No history of urinary incontinence. There is no history of seizures and involuntary movements. There is no history of loss of sensation, loss of balance or swaying while walking. There is no history of double vision, tinnitus, vertigo, ataxia. No history of swallowing and difficulty in swallowing and nasal regurgitation and hoarseness of the voice. No history of difficulty in neck shoulder movements. No history of pain or a burning sensation. There is no history of chest pain, palpitation and breathlessness. Past history. Known case of hypertension since 8 years and he is on treatment for the same. There is no history of similar complaints in the past. There is no history of transient ischemic attacks. No history of surgeries in the past. Not a known case of diabetes, ischemic heart disease, rheumatic heart disease, bleeding or clotting disorders, epilepsy and peripheral vascular disease. There is no history of allergies, any allergies. Drug history. Patient is on medication for hypertension since 8 years. There is no history of use of any anticoagulants. Family history, nothing significant. Personal history, diet, vegetarian, appetite is normal, adequate sleep, bowel bladder and bladders are regular and normal. Habits is smoker since 20 years. The smoking index is 40. Summary. A hypertensive elderly male smoker presented with sudden onset of weakness in the left upper limb and lower limb, associated with slurring of the speech and deviation of angle of mouth towards the right side. History suggestive of acute neurological deficit, probably due to the ischemic stroke, that is right side internal capsule, due to the thrombus in the right middle cerebral artery territory.
Wait. So you summarize the history as it is patient of acute neurological deficits. Okay, so if you go back to your chief complaints, we'll just discuss the history. Probably that's how we'll go. Yeah. So weakness in the left upper limb and lower limb since 10 days. That is the main presenting complaint, isn't it?
Yes.
Along with difficulty in the slurring of speech since 10 days. Now, whenever some patient comes to you with weakness, whether upper limb, lower limb, or all the four limbs, what are the few things you were, while approaching the history-wise, what are the things you are going to concentrate on? So, one of the main thing in neurological history taking is, what is the temporal evolution? Okay, now you said left upper limb and lower limb weakness since 10 days. So can you elaborate a bit more on that weakness?
Sir, initially weakness, when he went to the sleep, there is no weakness. And when he woke up in the morning, there is a weakness in the upper limb
Weakness.
and lower limb. Yes, sir.
So you have
And
to
his
always elaborate under 3 headings: onset, duration, progression of the weakness. Now,
sir, it is
onset
sudden.
here,
Sir.
it is acute onset
Sudden.
because patient was all right. He gets up, he has weakness. Okay. Then what is the duration? It is 10 days. Now, the
Yes, sir,
next
duration is
question, 10 days. The question to me is progression. Now, can you go to your history? Always, whenever you have weakness, it is onset, duration, and progression. Go ahead with the history.
Sir, he unable to when the
Right.
weakness
You
is
can change the
started,
slides.
he was unable to move his hands.
Okay. So now, if you can you show the history slide explaining the weakness? Yeah.
Next slide.
Yeah. Yes. No, the previous slide. Correct. Previous slide. Okay. Now, see, you have mentioned that he had weakness, the right upper limb and lower limb. Onset duration is answered. But what about progression? So to answer this question, you have to tell what was the weakness at onset and what has happened. There is all these 10 days because 10 days, this is the 10th day you are examining. So this gives us a lot of clue. Say, for example, the patient could not move at all his upper and lower limb at the onset itself, has a different meaning. Or patient could move a little bit of his upper limb and lower limb. Over few hours, few days, it became worse. Okay, that gives me
Sir,
a different
initially
meaning.
he is able to move.
Here,
After
what is the
that,
thing?
the progression happened, sir.
No. Here you have to tell me whether the weakness was complete at onset or did it progress over few hours or few days. Weakness.
It's progress, sir.
Progressed how long? How frequently? So what was the power? So that's why you have to explain. Say, for example, weakness of upper and lower limbs. Initially, he could not lift his hand above the shoulder, could not hold the glass, could not button, could not get up from sitting position, could not stand. Later, he could not even move a bit. So that is progression. That might have progressed for few days. The last 10 days has the weakness improved. So the entire, it is like a story. The weakness started. What was the degree of weakness historically? Then whether it did progress or it did improve over these 10 days. Why is this important?
Sir, in embolic stroke, the weakness is at the onset only, sir. Maximum weakness is present at the onset. But in thrombotic and embolic, there is a progression of the weakness will be there.
Weakness. So we'll come to it later. Now, I told you 3 important questions: onset, duration, progression. Any weakness. So how is this onset going to influence your history? Now, for example, in this patient, you said it is acute onset weakness. Okay. What if the weakness was progressive, say over gradually, over few hours or few days or 1 week? Or some patient might come to you with a history of progressive weakness over months. Okay, now you have 3 things. This is one case scenario where you have presented that the weakness is acute. Now you can have a scenario where the weakness progresses over weeks, isn't it?
Yes, sir.
Or you can have a scenario where the weakness progresses over years. So acute onset, subacute onset, and a chronic onset. So what do you understand when it's acute onset? What is your inference? For example, your case.
Yes, sir. There will be sudden onset of weakness will be there, sir.
Yeah, sudden or acute onset. Okay, yeah. What is your inference? How will it help you? So this will help you in the etiology. It is vascular event. So
Yes,
whenever
sir,
you have an acute onset, it is a vascular event.
Vascular.
So other things are head injury or any trauma to the patient. Or rarely some causes like bleed into a tumor. But those two we will keep it apart because there's a definite history. But whenever you have such history where you say weakness was not there, it came suddenly, then it is acute onset weakness. More or less says it is a vascular event. Okay. Now I said there is chances of subacute onset of weakness. So which conditions do you get subacute onset? That is days to weeks.
Sir, it meningitis and infectious conditions like meningitis and
infectious conditions like meningitis. Good. Then
and post seizure.
Post-seizure thoughts
Thoughts,
is a
thoughts
it
paralysis.
can manifest both ways. Still, it is considered as acute. Then there is a
Encephalitis.
particular
Encephalitis.
encephalitis. Okay, ADEM can cause weakness over days to weeks. Good, which is another weakness which starts then progresses over 1 week, which acute neuropathy. So demyelinating lesions. Again, demyelinating lesions can present as subacute. So same patient says it started about gradually, then progressed over 2 to 7 days, 10 days. You think of either infection, demyelinating lesions, or encephalopathy, as you said, encephalitis can be considered. What if patient says weakness progressed over years, months to years? It's a chronic onset weakness.
Maybe yes, sir. It may be
It
a
implies
metastatic tumor, sir.
a
Yes, sir.
tumor. Okay. More than that, what condition, what pathology you think of? It's a degenerative condition.
Yes,
Okay.
sir.
So now we have an acute onset, it is vascular. Subacute onset, you have infection, demyelination, and sometimes encephalitis. Chronic onset, more or less, it is degenerative. Sometimes, as you said, malignancy can also be a cause for weakness. So here, in your case, it is acute onset. Correct?
Yes, sir.
So
Yes,
it is a vascular event. So now
Yes,
in
sir.
vascular event, whether it is embolism, thrombosis, or hemorrhage, how will you tell this?
Sir, in embolic, the onset is weakness is maximum at the onset, sir.
Maximum at onset. That is very important. So embolism is bold from Lupu. That's what they call the weakness is complete at onset. Good.
Onset. But and in yes, sir.
What about hemorrhage? Correct. Go ahead. Go ahead.
Yes, sir. In hemorrhagic and ischemic, there will be a onset, sudden in onset and progression of the symptom will be there,
No,
sir.
embolism and ischemia come on one side. Don't get confused. Hemorrhage is on the other side. Yeah. Hemorrhage, how does it?
There will be
usually?
history of hypertensive patient will be there and history of trauma may be there, sir.
One or uncontrolled hypertension, history of trauma may be there.
And sudden onset of weakness, and there will be a progression of the weakness will be there.
Yes, there is sudden onset of weakness and there is progression of the weakness and occurs usually during height of activity, isn't it?
Yes,
That's
sir.
why that is typical of hemorrhage. Embolism can occur anytime, but most commonly in the early mornings. But hemorrhage, weakness occurs, it progresses. Most of the times it is not complete at onset, but gradually it can happen at a height of activity. What about this thrombosis? In between somewhere it comes. You have written thrombosis as a diagnosis. That's why I'm asking.
Sir, here also the early morning weakness. Early morning weakness will be there, sir, and it is also sudden in onset and progressive weakness will be there, sir.
Okay, it is early on. Sometime early morning is added this one. Acute onset, I agree. But how does it differ from embolism?
In embolism, the weakness is at onset of maximum weakness is present at the onset only, sir. But in thrombosis, the progression will occur, sir.
Okay, progression occurs over few hours. That is important. It is not that over days or anything. It can occur over few hours. That's why it is also called as a stuttering progression of weakness, because sometimes patient comes to you only with a facial deviation. After hospitalization, he develops a complete stroke. Many times the attendants say he came only with facial deviation. Now it has happened. So probably, they say your treatment has gone wrong or something, but that has happened because of thrombotic event. So it's also called as stuttering progression. Okay. Now, your case, it is vascular because it is acute onset. Now, do you want to tell whether it is thrombosis, embolism, or hemorrhage?
Sir, probably embolic. Sir, it's not hemorrhagic.
Of course. Yeah, unlikely to be hemorrhagic, even though he is hypertensive, but the way it has come, complete onset, that weakness at onset, and early morning, again, probably think of an embolic phenomena here. Unlikely to be thrombosis also. We don't know. That may change gradually later. Now, onset and duration has given you a clue. Progression also, that's how it has helped. Okay. Now, further, you said patient has slurring of speech. So, what is that? How do you define? I mean, how do you explain that here? Slurring of speech.
Sir, it's a patient has slurring of speech for since 10 days, sir. It is sudden in onset, and he was able
Okay.
to understand the command.
So you are trying to tell that he is able to understand and comprehension is good. Only thing
Yes,
is
sir.
speech is not fluent. Okay.
Yes,
So
sir.
probably you are trying to tell a particular thing like Broca's aphasia or anything. You will come to it
Yes, sir.
once we do examination, and we will come back to it. Now, where do you place the lesion? Before that, so for example, now you have an vascular event. Sure, that is vascular
sir.
event. Now in
Yes,
vascular
vascular
event, that is so whether you want to see whether this hemiplegia can occur because of cortical lesion, it can occur because of subcortical lesion. In subcortical, either it can be internal capsule or corona radiata, or it can occur in brainstem. Yeah, brainstem.
Brainstem.
Now, where do you want to place the lesion based on your history?
Sir, in the
Cortical,
internal capsule, sir.
you want to think of internal
Subcortical,
capsule.
sir.
Yeah, subcortical internal capsule you think of.
Yes, sir.
So how does cortical weakness differ from subcortical?
Sir, in cortical lesion, there will be a loss of consciousness and seizure will be there, sir.
Seizures might be there. Loss of consciousness is not always there. Okay, then predominantly what will be the presentation because of the large
Aphasia will be there.
Yes, and plus most of the times it is monoplegia which presents along with seizures rather than hemiplegia and the cortical involvement. And as you said, depending upon the right or left side, you have certain other features. Okay, in cortical lesions. Plus seizures again favor cortical, it can occur anywhere. Okay, because of the reticuloendothelial endothelial activation. Now, subcortical internal capsule versus corona radiata. How will you differentiate?
Sir, if it is in the internal capsule, there will be a dense hemiplegia will be there, sir.
It is dense hemiplegia because all the fibers are compactly present in that anterior. It's a dense hemiplegia. Good. Then there is facial deviation. The only cranial nerve which can be involved is the facial nerve.
Seventh nerve, sir.
Opposite side. So corona radiata can also have the same thing. How do you differentiate corona radiata from internal capsule historically?
Sir, I am
The
not
thing
sure.
is, yeah, internal capsule, the upper limb and lower limb weakness are proportionate always. Both are same. It's a very dense area, as you said. In that small area, all the fibers are there. So all the fibers are equally affected. So it is proportionate. Whereas in corona radiata, it may not be proportionate because it is a widespread, widely fanned out area. The involvement may not be proportionate. That is upper limb and lower limb. That is, there is a disproportionate weakness of upper limb and lower limb. Similarly, it can also have facial nerve. Here also it can have facial nerve. How does brainstem lesions present? Now, you thought of cortical, thought of subcortical, coming to brainstem.
Sir, in brainstem, the crossed hemiplegia will be there, sir.
Crossed hemiplegia plus what else will be there? More than that, historically. Patient will present with history of lower cranial nerve involvement. That's why you have given such a long set of negative history, isn't it? Cranial nerve negative history. So that is to what a brainstem. Yes. Lower cranial nerve involvement. That is basically they present with hemiplegia along with vertebrobasilar insufficiency symptoms. That is, patient can come with giddiness, vomiting, lower cranial nerve involvement. All these probably tells you brainstem involvement. On examination, of course, as you said, there is crossed hemiplegia. That is opposite side. That also again gives you a clue for brainstem. So cortical, now it's a vascular event. Cortical, subcortical, brainstem. Where do you want to place your lesion?
Subcortical, sir.
You want to think of a subcortical lesion? Probably yes. Okay. And you said it is vascular event. Which arterial territory you think of?
Sir, probably it's a middle cerebral artery territory.
Middle cerebral artery territory. So how to differentiate MCA, ACA, and posterior circulation? Now, if there is hemiplegia, either MCA is involved, or the ACA is involved, or the posterior circulation. How will you differentiate?
Sir, in anterior cerebral artery, the weakness is more in the lower limb, sir. Lower
limbs. So can you explain why? Can you tell why?
Sir, in homunculus, sir, the presentation of lower limb on the medial side, sir, and medial side of the brain is supplied by anterior cerebral artery.
So it is the anteromedial strip where the lower limb comes, isn't it? As you said.
Yes,
and then large representation of the homunculus is the lower limbs, which is supplied by ACA predominantly.
Anterior cerebral.
Anterior cerebral artery predominantly. So in anterior cerebral artery involvement, lower limb weakness is disproportionately more than
upper.
Then what are the other differences?
Like if frontal lobe is involved, sir, there will be urinary incontinence will be there, sir.
So bladder involvement, which is
Yes.
generally not at all a feature of hemiplegia, can happen with ACA because of the prefrontal cortex involvement. That is second. Third,
Sensory loss will be there.
sensory loss, it's difficult to differentiate between MCA and ACA. Then behavioral abnormalities.
Behavioral
Accompanying
abnormalities.
hemiplegia again favor anterior cerebral artery. So lower limb involvement more than upper limb, behavioral abnormality, probably bladder involvement tells you it is ACA. MCA territory, what is the classical features of MCA territory?
In MCA territory, sir, mainly aphasias will be there, sir.
Okay. Speech involvement. There is speech involvement.
Speech involvement and motor.
First describe about the weakness. First describe about
sir,
the
contralateral weakness will be there, sir.
Contralateral weakness, upper limb more than lower limb or upper limb equal to lower limb, not lower limb more than upper limb. Posterior circulation, I think we discussed about brainstem. Similarly, what is the main presentation of posterior circulation?
Lower motor cranial nerves involvement will be there.
They come with what? They come with vertebrobasilar symptoms like
ataxia, vertigo,
vomiting, ataxia, hearing difficulty, and other lower cranial nerve involvement. So ACA or MCA territory, facial nerve involvement will be there in MCA territory, especially. Okay, so when you're talking of internal capsule or the corner radiata again, that can happen. Okay, so this is now ACA versus MCA versus PCA. Here, where do you want to place your lesion?
So MCA, sir.
You are thinking of MCA.
Okay.
So as of now, historically, based on your history, it is vascular event. It is probably an embolism. It is subcortical and probably MCA territory involvement. Okay. Now, history-wise, first you are trying to look into this. What might have caused is the next question history-wise you have to ask. Okay. So what risk factors history you have taken in this patient?
Sir, any cardiac diseases like
so first is hypertension.
Like atrial fibrillation.
Stroke, first, whenever you're talking of stroke, one thing you have to remember is hypertension. That is the most common modifiable risk factor for stroke. Okay, hypertension. Then you talk of cardiac conditions. Okay, so what cardiac history you have taken in this patient?
Sir, chest pain and palpitations and breathlessness history.
Chest pain, palpitation, and breathlessness. Why this palpitation is important?
Sir, atrial fibrillation causes dislodgement of the emboli from the cardiac.
So, say for example, your patient had a known case of rheumatic heart disease. Okay, so he was on treatment for the same on anticoagulation if required, if there is a thrombus. Now suddenly he develops palpitation, probably reflecting atrial fibrillation. There might be dislodgement of the clot. Okay, so that's why chest pain, palpitations, and breathlessness history is important. What are the other negative history? You have written so many. You can change the slides and we'll discuss the negative history. Yeah. No history of headache, nausea, vomiting. How is it helpful for you? Headache, nausea, vomiting. History of headache. Very important when you're talking of stroke. How does that help you?
Sir, if there is a history of headache, nausea, vomiting, there will be increased intracranial pressure will be there, sir.
Okay, vomiting, is it all types or is there any specific type?
Projectile vomiting, sir.
Projectile. When do you call it as projectile vomiting?
Sir.
When is it projectile? When is it non-projectile?
Sir, if in meningitis condition there will be increased intracranial pressure, that time there will be a projectile.
What symptom? For example, patient says vomiting. When will you say it is projectile? When you say it is non-projectile?
If vomitus is spilling on his body, if spill on his body is non-projectile and it is away from the body.
If the vomiting or vomitus is not preceded by nausea, there is acute sudden vomiting, probably it is projectile vomiting. Preceded by nausea and there's always this discomfort, epigastric discomfort, he says probably it is non-projectile vomiting. Okay, so severe headache with projectile vomiting probably tells you there is raised intracranial
Intracranial
tension.
pressure.
How else the headache helps in your history? So severe headache again is a feature of hemorrhage.
Yes, sir.
Severe headache patient can have bleed, hypertensive bleed, then probably patient experiences severe headache. Third, if the young patient comes to you with non-specific weakness, not exactly hemiplegia, where you cannot localize, he says severe headache. This is the first time he has experienced such headache of his life.
Subarachnoid hemorrhage will be there.
Subarachnoid hemorrhage. So that is another thing you have to think. Rarely there is an entity called migrainous hemiplegia where there is severe headache followed by weakness. But of course, it is very rare. Okay, so you think of bleed or subarachnoid hemorrhage, there is severe headache. Think of raised ascites when headache is associated with projectile vomiting. So that's how this headache helps. Rare causes like migrainous hemiplegia. Then you have written no history of trauma. That is again important. No history of loss of consciousness. Probably sometimes, as you said, cortical versus subcortical, but it's not again. Sometimes what happens, patient comes to you, his sensorium is better. Over 2 to 3 days, sensorium deteriorates. What do you come? When does it happen? Especially once you start treatment, patient sensorium deteriorates. Should always tell that. There is something called as reperfusion edema that happens. So normally, patient, whatever sensorium he had after an acute stroke may deteriorate after 48 hours. So again, loss of consciousness. Again, you have to tell about the temporal evolution of consciousness. Then altered sensorium, behavioral abnormality, we have already discussed. Urinary, as I told you, hemiplegia will not have any bladder involvement. If at all there is bladder involvement, sometimes probably you think of an acetylatory involvement. Seizures, involuntary movement, again is important. So you were talking of TODS palsy, that might come here. Acute onset, and that's one. Next slide. No history of loss of sensation. Probably you are telling to tell there is no sensory involvement. But if at all you have a dense hemiplegia, there is sensory involvement also sometimes. Okay, may not be there. And you can go back. Yeah. No history of loss of balance or swaying while walking. So there is an entity called as ataxic hemiparesis. Anyway, don't worry about that. But there is sometimes, there are different causes we think. When patient presents to you with weakness plus ataxia, then there is a separate component called ataxic hemiparesis. Okay, ataxic hemiparesis. Then you have written about history of tinnitus, vertigo, swallowing, nasal regurgitation, hoarseness, all trying to rule out the
cranial nerve involvement.
Involvement. Again, neck shoulder movements, burning sensation, chest pain, palpitation, and breathlessness. So that's why you are trying to rule out the negative history. Another important history always you have to consider is history of fever. History of fever in weakness is very important. Say, for example, patient had fever. He developed weakness later, say the 3rd or 4th or 5th day. Probably infection has to be considered. That is an important thing. Okay, next. Next slide. Yeah. Now, of course, in past history, you have spoken about hypertension. It's always a present history, hypertension, diabetes. Don't put it in past history. Okay. Then you have written about history of TIA. What do you mean by TIA? What do you understand by the TIA? What TIA?
Sir, it's a brief episode of focal neurological deficit, sir. Because of brain involvement or retinal ischemia, which the symptom lasts for the less than 24 hours without actual infarction, sir.
Without actual infarction. So now if you have to tell TIA, it's always a retrospective diagnosis. So there is brief loss of consciousness. Patient reverts back within 24 hours, generally within 2 to 4 hours. And there is something called as a tissue diagnosis here. That means on neuroimaging, there should not be any infarction. That is very important. So always it's a retrospective diagnosis. How is this history of TIA helpful for you?
So repeated attack of TIA may lead to the stroke, sir.
Now, if there is a background history of TIA, what clue does it give you in this patient?
Sir, there will be a weakness in the contralateral weakness, sir, and amaurosis.
No, that's okay. Weakness is there. Say, for example, this patient says, I had history of TIA. So how does that clue help you in your diagnosis? It is an important clue to say that present event is also probably embolism, unlikely to be hemorrhage. Okay, so past history of TIA is a very important clue to you in thinking probably this patient has embolism over hemorrhage. Then you have written history of IHD, RHD, okay, clotting disease, epilepsy. Another important history in Indian setup is history of tuberculosis. That has to be mentioned, especially if a patient had an attack on treatment or has received treatment, that has to be mentioned. Why?
Say
Say for
tuberculoma
example,
can also cause
yeah,
Crohn's
TB
disease.
CNS involvement is common. One, TB vasculitis can present as different varieties. One of the way it presents also is hemiplegia. That's why history of fever, history of TB has to be required in our setup. Of course, history of drugs, any medication intake, all those history you have to include. Okay.
Yes.
So now with this background history, what is your diagnosis? So first explain the weakness.
Well,
What is the
yes, sir.
weakness? It is left-sided
Upper and lower limb
Hemi-
weakness.
hemiplegia.
Hemi-
Left-sided hemiplegia,
Paralysis.
probably due to,
Vascular variations.
no, you know, what is it? Probably due to embolic phenomena in
Embolic
the
stroke.
embolism in the right
Right internal capsule, sir.
MCA territory. Right,
Yes, sir.
MCA territory,
Involving
probably
MCA.
internal capsule, with involvement of internal capsule, probably internal capsule. Risk factors being
Hypertension, sir.
hypertension. So this is your complete history. No, diagnosis, historical diagnosis. Okay. Now with this background, you go on to next. Anyway, I am not discussing about paraplegia, monoplegia, or quadriplegia presentation, because while localizing, if it is a lesion, you cannot just stop at brainstem level. We generally come down probably the spinal cord, anterior horn cells, peripheral neuropathy, peripheral nerves, muscles, neuromuscular junction. That's how we go, and the muscles. Okay. But here, since it is hemiplegia, we'll restrict it to it. Next half an hour, we'll finish the examination. Okay, go ahead.
General physical examination. Patient is conscious, cooperative, well oriented to time, place, person, and he is moderately built and nourished. His height is height is 150 centimeter, weight is 55 kg. BMI is 24.4 kg per meter square. Pallor, icterus, cyanosis, clubbing, lymphadenopathy is absent. Head to toe, vital slide.
It's missing. Okay. Yeah, you tell the vitals.
Yes, sir. Blood pressure is 140 by 90 mmHg. Pulse rate is 82 beats per minute, regular rhythm, normal volume and character. Condition of the vessel wall is normal. And there is no
Okay.
radial and radiofemoral delay, and all peripheral pulses are felt on bilaterally. Respiratory rate is 18 cycles per minute, and it is abdominothoracic. Temperature is 37 degrees Celsius.
So what is the importance of temperature and pulse rate here? What is the pulse rate you said?
Sir, 82 beats per minute.
82 beats. So it is normal. Say if the
Yes.
patient has bradycardia and hypertension, what does it tell you?
Sir, it's a Cushing syndrome.
Yes, it again a sign of raised intracranial tension. So patient has fever, background history, tachycardia, probably again tells you an infective cause as the cause for the weakness. Or persistent tachycardia can be sometimes seen in hemorrhage, bleed patients. Okay, so pulse rate is important. You have mentioned all the peripheral pulses are felt. That is very important that you examine all the peripheral pulses. Specifically, there is one entity where sometimes in elderly people with headache and weakness, you have to examine temporal arteries for temporal artery tenderness. Why is that?
Sir,
Rarely there is something called giant cell arteritis which can present with weakness. Okay. So not only you mentioned about the all the peripheral pulses. In elderly patients, sometimes you'll have to mention about there is what is called temporal artery tenderness. Okay, if it is present or absent. So if it is bradycardia, it gives you a certain clue. Tachycardia, it will give you a clue. If it is irregularly irregular, again it will give a clue that there is atrial fibrillation, probably
atrial
causing.
fibrillation. Yes, sir.
Okay, so that's important. Again, blood pressure is important. High blood pressure or very low blood pressure again will give you a certain clue. So vital examination, vitals are very important in central system examination. Okay, go ahead, next.
Head to toe examination. Hairs are black and evenly distributed. Eye is normal. There is no pallor and icterus. Ear, there is no discharge. Nose, there is no discharge and no DNS. Oral cavity is normal. No engorged neck veins. No swelling in the neck. Spine is normal. Upper limb and lower limb on right side it is normal. Left side there is a weakness present. There is no cyanosis and clubbing or pallors.
That weakness you need not present here in the head to toe examination. You can sometimes mention what is called as decubitus of the patient. Either in CNS examination or in head to toe, you can mention what is called decubitus of the patient. What is decubitus of the patient?
Sir, the patient, position of the patient in the bed, sir.
Position of the patient on the bed. So what happens is whenever there is hemiplegia untreated for a long time, patient will have a particular posture, isn't it? Upper limb flexed, internally rotated, flexed at the wrist. Or lower limb extended, externally rotated. So that if it is there untreated, you have to mention. You need not mention about the weakness in GP, that is head to toe examination. Anyway, we will be talking about that in CNS examination.
Central nervous system examination. Higher mental functions. Patient is conscious, cooperative, well oriented to time, place, and person. Speech. He uses appropriate words while talking. Repetition is present, but there is a difficulty while talking, sir. Word output is normal. Appearance and behavior is appropriate. He is emotionally stable and the calculation is normal.
Okay, now speech, get back, you have written something about the speech. How do you explain that? Go back to the previous slide. Yeah. So what is your conclusion with the speech?
So there is no aphasia present, sir. Only dysarthria is present.
Only dysarthria. What is aphasia? What is dysarthria?
Sir, in aphasia, the language component of the speech is defective, sir. In dysarthria, there is a disarticulation of the words will be there.
See, what happens is one is the functional aspect of the speech which is involved, that is aphasia. Then, as you said, dysarthria is basically there is articulation defect. Okay. Uses appropriate words while talking, repetition is present, but there is difficulty while talking. Dysarthria, there is no difficulty in talking. His articulation is a problem. Okay. So, what are the types of aphasia you know of?
Broca's aphasia, Wernicke's aphasia, sir, and
Wernicke's aphasia and
transcortical
aphasia. Yeah, conduction aphasia. Then you have transcortical aphasias come. Broca's aphasia. What happens in Wernicke's aphasia? Patient's comprehension is poor.
Yes, sir.
So when you ask a particular question, the answer is irrelevant. But his Broca's area is intact, so speech output is normal. Good and normal, but the answer will be irrelevant.
Yes, sir.
Okay, that happens in Wernicke's aphasia. What happens in Broca's aphasia?
And the fluency is absent, sir. His word output is zero.
Not absent, it is not there. It's a non-fluent speech, but it is comprehension is good, but yes. So the answer is relevant to the question you have asked. Isn't it? That is Broca's. Conduction is similar to Wernicke's. That comes up. Then repetition is present. You have stressed on that history also and examination also. How does it help you?
Sir, repetition is mainly absent in conduction aphasia, sir.
See, repetition is bad in it is not correct in Broca's, Wernicke's, and conduction, but it is worse in conduction. Repetition is present only in which type of aphasias? Or intact? It's not called present. It is intact in transcortical. So when you stress on that repetition is intact, that means you are trying to tell it is transcortical aphasia. Okay. It is affected in Broca's, it is affected in Wernicke's, it is affected in conduction. But it is worse in conduction aphasia. That is, if there is involvement of the conduction fibers, then it is worse. It is intact only in transcortical aphasias. So are you telling probably this is transcortical aphasia, or probably we are thinking of Wernicke's here or Broca's?
No, sir.
Now coming to dysarthria versus Broca's, how will you differentiate?
Sir, in dysarthria, the particular words like which cranial nerve is involved, based on that the word
Good. So
Disarticulation is
probably how you put it is dysarthria is again difficulty in speech. Probably there is no fluency to a particular
cranial
words.
nerve, sir.
Yeah, cranial or whatever, say local, because of the local problems. So you have linguals, labials, and gutturals. So if there is involvement of the tongue muscles or the tongue, then the linguals are more affected than the labials, isn't it?
Yes.
So each word is divided into whether it's a lingual, labial, or guttural,
Yes, sir.
depending upon whether the tongue is used or the lips or the palate is used for pronunciation.
Yes,
So
sir.
dysarthria, only those particular set of words are involved. The others are intact.
Yes, sir.
Broca's aphasia is not like that. Across all, there is difficulty in speech. Plus, what else is there in Broca's? He speaks very less. I think that history you have given me. So I was thinking you are trying to tell me it is Broca's. He speaks very less. The word output is very low in Broca's aphasia.
Because of-
And he speaks in short sentences in a low voice. That is Broca's aphasia. So it is a non-fluent speech. One, word output is less. Two, and speaks in a low voice. That is Broca's. Dysarthria, there is no issue with all this, but whether depending upon what is involved, either linguals, labials, or gutturals, there is a particular problem. Okay. So here finally, what do you think? It's dysarthria or aphasia first?
Dysarthria, sir.
Dysarthria. So you feel he was able to pronounce certain words, but only certain.
Yes,
You will
sir.
have to explain me what cranial nerve is involved later. Then you cannot tell upper motor now.
Yes,
You
sir.
come to the articulating system. Okay, probably with all this, it looks to me like a Broca's aphasia. Okay, we'll
Okay,
go
sir.
to it. Yes. Anyway, you have examined the patient. Next, appearance, behavior, appropriate, emotional stable, calculation. Okay. Next.
Cranial nerve, sir. Olfactory nerve. It's a normal on both.
So you
Right.
can go to all the other cranial nerves are normal. What
Normal.
about seventh nerve? Yeah.
Next slide.
Seventh nerve.
The seventh nerve. There is a forehead wrinkles are present, sir, on both sides. There is patient is able to close his eyes, and there is a nasolabial fold is normal, and deviation of angle of mouth to the right side, and the person is not able to whistle and hold the air in the mouth, and
So
anterior
with
two-third.
this, it's UMN or LMN first? Which
It's a
side?
UMN, sir. UMN
So
type
deviation
of
of angle of mouth present which side? I can't see that.
it's a normal side, sir. It's a right side, sir.
No,
It's
no,
on right.
here it is deviated to
Right
side.
side. Yes,
So
sir.
which side is involved? Right or left? Facial nerve.
Left, sir.
Left side. UMN or LMN?
UMN, sir.
UMN. How do you differentiate UMN and LMN facial nerve?
Sir, in UMN facial nerve palsy, there is only opposite side lower face is involved.
Lower half of the face is involved. The upper part is spared.
Yes, sir.
Whereas in LMN facial nerve, there is both upper part and lower part. The entire half is involved. Why is that?
Sir, because of dual cranial nerve representation, sir.
Representation in the upper lip. Okay, so your upper part of the face is normal.
Yes,
Is
sir.
it? Okay. So it is left UMN type of facial nerve palsy. What is the cause of bilateral facial nerve palsy? Bilateral LMN type of facial palsy.
Brainstem involvement, sir. Hemorrhage in the brainstem.
Which infection? Two infections, one common. Leprosy, again, can Hansen's can cause bilateral. Okay. And similarly, rarely in sarcoidosis or GB syndrome, you can get bilateral facial nerve palsy. Okay. Yeah. Next. All other cranial nerves are normal.
Yes, sir.
So only you have left
Seven.
upper limb, left UMN type of facial nerve palsy.
Yes, sir.
Yeah. Next.
Attitude of the patient. Motor system examination, sir. Attitude of the patient. Upper limb. On the right side, the patient is adducted at the shoulder joint, extension at the elbow, and supination at the forearm. In the left side, there is adduction at the shoulder joint, flexion at the elbow, pronation of the forearm, flexion of the wrist, sir. In the lower limb, on the right side, there is an extension of the hip and knee joint. On the left side, there is extension of hip and knee
So
joints.
what do you call it as pyramidal weakness when you use the word pyramidal weakness?
Yes, sir.
When they use the word pyramidal weakness, what do you understand by that? So distal more than proximal and extensor more than flexor in the upper limb, flexors more than extensor in the
Lower
lower
limbs.
limbs. So that is a pyramidal weakness. So whenever you're trying to explain in such probably pyramidal factors, that is what you have to think. That's how it will be affected. Okay.
Yes.
Next, bulk. Okay. It's normal. Is this affected?
No atrophy, sir. Yes, sir.
Okay. No atrophy.
Yes, sir.
Okay.
Tone, upper limb flexion, sir. Flexion and extension. In the right side, it is normal. Left side, it is increased, sir.
Increased. Okay.
And in lower limb and
Next.
flexion extension, right side it is normal and left side it is increased.
Increased. Okay. Power. So here if I see the examination, it is almost equally affected, isn't it? But
Yes, sir.
generally, I told you whenever you're talking of a pyramidal weakness, space the anti-gravity group of muscles, but so distal more than in case of upper arms as well as your extensor more than flexors, whereas flexors more than extensor in legs. Normally, that is the pyramidal weakness distribution. So you have to, while writing the power, you have to be careful. How do you grade power?
Yes, sir. If it is a grade 0, there is no power at all, sir. There is no
Yes.
movement at all. If it's a grade 1, flickering movement will be there.
Flickering movement.
In grade 2, there is a
Grade-
movement is present without gravity, sir.
So eliminating the gravity is able to move. Grade 3 is
With patient can elevate the limb with the gravity without resistance.
but no
sir.
resistance offered. 4 is mild minimal
Patient can
resistance.
elevate the limb with gravity as well as with some resistance.
5 is normal power. Okay. Yeah. So it's almost uniform weakness, 3/5. Anyway, that's you have to examine properly. Okay. That can happen over some days. It's not that always it should be like that. Okay, next. Yeah. So it
There is
is
a
reduced power in the left upper
left
limb. Lower limb. Next.
Reflexes, sir.
Reflexes.
Superficial reflexes, corneal, conjunctival, abdominal reflexes are present on the right side and it is absent on the left side, sir. Plantar reflex, there is a flexion on the right side and it is extensor plantar reflex on the left side, sir.
Oh.
Deep tendon reflex. Biceps, triceps, supinator, knee.
Or all exaggerated.
It is +3 in the left side, sir.
So it is all exaggerated, you want to tell.
Yes, sir.
Now, how do you differentiate UMN and LMN weakness? Now you have written the entire motor system examination. How will it?
Yes.
How do you differentiate UMN and LMN?
Sir, in UMN paralysis, there will be a single group of muscle is affected, sir. In
So that's what you can have a pyramidal weakness or an extra pyramidal weakness. LMN is that particular nerve and that particular group of muscles are involved. Okay, then.
In UMN paralysis, sir, there will be hypertonia will be there. In LMN, hypotonia is there, sir.
So there is hypertonia in the UMN. LMN there
UMN
is
paralysis.
hypotonia. Which UMN condition you have hypotonia?
Sir, septic shock condition, sir. UMN with shock.
So if patient is in neurogenic shock, it is not septic shock. And in initially neurogenic shock, there is hypotonia. Then any other condition you have hypotonia?
Sir, I don't.
Cerebellar system involvement. You can have hypotonia. Okay, so these are the two UMN conditions where you can have hypotonia. So one is weakness. You have distributed, explained about the weakness. Then you have commented on the tone. What are the other differences? What
Sir,
about
in reflexes,
nutrition? Before that, nutrition. So there is, where do you get early atrophy?
sir, in element palsy, sir.
Element type. Early atrophy is a feature of element.
Element.
Late or
Disuse
disuse atrophy
atrophy
is
is
a feature
present
of
on
UMN feature.
UMN,
Okay, next.
sir. In reflexes, sir, in superficial reflexes are absent in both. Deep tendon reflexes are exaggerated in a UMN and absent or decreased in LMN, sir.
Okay, so there is hypertonia, there is exaggerated reflexes, isn't it?
Reflexes.
Any condition where there is hypotonia but still reflexes are exaggerated. Generally, whenever there is hypertonia, there is exaggerated reflexes.
Sir,
So again, cerebellar system involvement. The reflexes, what is called as, what type of reflex is seen when you in the test? In cerebellar system?
not sure, sir.
Okay, we'll see. So then again, hypotonia with exaggerated reflexes are seen. What are the other differences, UMN and LMN?
Sir, in UMN, there is a Babinski sign is positive, sir.
Okay, so when we talk of Babinski sign, there is no negative. Babinski sign tells you it is extensor pattern. Okay, you need not tell about negative or positive. So Babinski sign is feature of, very classical feature of UMN lesion. Whereas flexors, there is plantars are flexors in LMN lesion. Okay, what are the components of Babinski sign? Components of Babinski. So when you do a Babinski, what are the things that happens? One, there is dorsiflexion.
Great toe. Yes, sir. If it is normal, there is a dorsiflexion of the great toe and other fingers, sir. Other toes, sir.
And fanning of the other toes.
Sir, yes, if it is a positive dorsiflexion of the great toe and fanning out of the other toes.
Then it goes on. It is just to stop there. There is dorsiflexion of the ankle, knee flexion, hip flexion, and there is something called as minimal Babinski. That is, there is only tensor fascial lata contraction without any other sides. That is called as minimal Babinski. So if you see the entire Babinski components, dorsiflexion of the great toe, fanning of the toes, dorsiflexion at the ankle, flexion at the knee, flexion at the hip, and tensor fascial lata contraction. So there is a component called as minimal Babinski, where there is, other things may be absent, but there is only tensor fascial lata contraction. So you have to look for all these when you are trying to do. The other thing is reflexes sometimes may not be elicitable. So you do what is called as Jendrassik maneuver, that is reinforcement. So either ask the patient to clench their teeth or hold the hands like this together so that you exaggerate the reflexes. Sometimes it may not be here anyway, it is exaggerated. So these are the, what are the other methods of eliciting plantar?
Sir, Chadocks.
Yes.
Chadocks methods. Sir.
Chaddock, Gordon's.
Gordon method.
Upper limb.
Open hem.
Yes. And Wartenberg's. Correct. So both you can look. But both these Wartenberg's and open hems, one thing you remember, only if it is unilaterally it's affected, then if it is sometimes bilateral, it may not give you much information. Okay, so unilateral there. So Babinski sign. So here plantars are extensors. Is it?
Yes.
Plantars are extensor. Probably again telling you it is of course it is a human lesion. We are not telling. Any condition where there is plantar extensor and absent knee jerk, absent ankle jerk. Because generally plantars are extensor in human lesion and reflexes are exaggerated in human lesion. Now, is there a condition where ankle reflex is absent, but plantars are extensors? In subacute combined degeneration, vitamin B12 deficiency, sometimes you get that because of the associated neuropathy, the ankle may be absent, but there is plantars are extensor. Okay. Then there are, of course, other rare conditions which can be because of this, but this is one of the common condition is subacute combined degeneration. Okay, go ahead with other examination. So with this, we are just, whatever we have made the diagnosis in history, we are trying to reinforce the same. Additionally, we have not got anything much further. Okay, so it is the same UMN lesion. with we have quantified the power. Then,
Sensory
and you have to
system.
read about all the root values of all the reflexes
Yes, sir.
from biceps to ankle. I will not go into it. And the important of each. Say, for example, when you're talking of biceps, it is C5, C6. But which is the most dominant dermatome there? It is C5. Okay, so that you have to know of all biceps, triceps, supinator, knee, ankle, and plantars. Go ahead, you can read that. Root values. Next.
Sensory system, sir.
It's normal.
Yes, sir. It's normal.
Sensory system is normal. Okay.
Cerebellar system is also normal. There is no signs.
Cerebellar system is normal. So this is what I was telling you. Sometimes when you have a suspicion, pendular knee jerk. So even though there is hypotonia, there is pendular knee jerk. That is at least more than, when do you say it is pendular knee jerk? More than 3 full cycles of movement of knee contraction, then probably you call it as pendular knee jerk. So no cerebellar signs. What is the minimum power to test cerebellar signs? Do you test cerebellar signs in all hemiplegic patients? You cannot, isn't it? So minimum means it should be more than 3/5. Probably you just escaped. So you should not write about cerebellar signs when it is 2/5. You only told because they cannot do movement against gravity. Anyway, that's okay. But you have to test all the signs of cerebellar signs. Then
meningeal signs, sir. Neck
meningeal
rigidity.
signs are absent.
Yes, sir.
What
Kernick
is
signs.
Kernick sign? How do you do? And what is
Sir,
Bredinski sign? How do you do?
yes, sir. In Kernick sign, we have to flex the hip joint and knee joint, sir.
Okay.
After that, we have to extend the knee joint. While extending, there is a pain in the hamstring muscle, sir.
Okay. Then Bredinski sign.
Brudzinski sign, sir. If we flex the knee, there will be a flexion of the hip joint, sir.
Hip joint.
Or flexion
Okay.
of the one limb cause flexion of the other limbs, other hip
So
joint.
again, all these you are trying to stretch the inflamed meninges causing pain. So okay.
Yes, sir.
And you should be able to differentiate that from meningism. Can be seen in certain diseases like enteric fever. Okay. Next. Gait.
Gait is hemiplegic.
Yes, what is hemiplegic gait? Describe a hemiplegic gait. Also called
circumduction gait.
Circumduction gait. Okay, so it's a circumduction gait. What type of gait do you get in Parkinsonism?
Sir, short shuffling gait, sir.
Short shuffling gait, also called as Fustinian gait, isn't it?
Yes, sir.
Short shuffling gait, walking as if he's trying to catch his own gravity. So small shuffling rise. What type of gait do you get in neuropathies? Peripheral neuropathy?
Peripheral neuropathies.
High stepping gait, sometimes in
yes, sir,
neuropathy. Waddling gait? Where do you get waddling gait?
Bilateral paralysis of the
proximal muscle.
Yes, sir.
That is proximal at one more time. Then you get waddling gait. Okay. Yeah, next. So other systems are normal. Very important. Yes, you have to look for central cardiovascular system and respiratory system. Yeah. Diagnosis.
So it's sudden diagnosis: sudden onset left-sided hemiparesis with UMN facial palsy. Due to the cerebrovascular accident, possibly the embolic in etiology, suggestive of lesion in the right internal capsule, probably involving the middle cerebral artery territory.
So can you modify this further? Can you rephrase it better way? Whatever diagnosis you have put it, but so sudden onset you need not tell in the diagnosis. So your diagnosis is first is just a weakness. It is left-sided hemiplegia or hemiparesis. Yes. With human facial palsy. Which side you have to mention? Okay, left-sided hemiparesis with right human palsy or left human palsy. Okay.
Left human palsy.
Cerebrovascular accident, probably due to embolism in the
embolic etiologies.
Right or left MCA territory? Right MCA territory.
Left MCA territories.
No, but your weakness is left hemiparesis. So it should be in
right MCA territory.
contralateral.
Yes.
What about cerebellar? If left-sided cerebellar is involved, which side will be the weakness, or which side will be the
Same side, ipsilateral weakness will be this.
ipsilateral weakness in cerebellar? Why is it so?
So double cross.
Double crossing. So here it is contralateral, there it is ipsilateral, double crossing. Okay, so left-sided MCA territory probably involving the right internal capsule, anterior 2/3, sorry. That I think. Okay, how will you investigate this patient?
Sir, when we'll investigate for if normal routine investigations like complete blood count, sir, and platelet count, prothrombin time and partial prothrombin time, like factors protein C, protein S, if there is any coagulation.
Stroke in young is a different workup. Normally, so what is it nowadays? How, whenever you have a suspicion of stroke, how will you investigate? Because
Sir,
now
first
it is
we will
like
do
MI. You are
CT
going to
brain we will
thrombolize
do,
the
sir.
patient. Golden hour.
Sir, we will do CT brain, sir, to rule out the
So
hemorrhage.
neuroimaging to rule out a bleed.
Yes,
Okay,
sir.
definite weakness is there. No contraindications. You have to thrombolize the patient. So I think now you have to know treatment of stroke as thrombolysis. What are the indications? What are the contraindications? And that keeps changing. Probably when we read it is 3 hours, 6 hours, 18 hours, it was changing.
Yes.
Because the whole thing starts from whatever we have discussed from diagnosis when a patient comes. Suspicion, do a neuroimaging, do a thrombolysis if it is indicated. It is life-saving as well as the deficits are reduced. What drugs do you use in cerebral vascular accident?
Sir,
You have to know about that. Thrombolysis
sir,
drugs
for
used.
thrombolysis, tenecteplase and alteplase are used, sir.
Alteplase are used. Mechanical thrombectomy, you read about that a bit because now it is changing. Stroke paradigm is entirely changed. In emergency ward, how do you suspect stroke? What are the acronym used?
Yes, sir, ABCD2, sir. Sir, if age of the
ABCD2
patient.
is a scoring for TIA. ABCD2 is
Yes,
a
sir.
scoring for TIA. Generally fast. What is fast? Anyway, know about that. Maybe not be for the examination purpose, but per se in casualty you have to know about that. Okay. So investigate the treatment. What drugs do you use if it is infarction?
Sir, like antiplatelet drugs are used, sir, like aspirin, clopidogrel.
Aspirin and
Clopidogrel.
And what else you want to start the patient on? Statins. Another
Statins, sir.
important drugs you have to give the patient. Of course, thrombolysis is the primary when there is infarction. Hemorrhage.
So blood pressure, we should control the BP, sir, first.
BP, again, there are certain protocols to do it. It is not always there. Then, based on the protocols, control of blood pressure, treatment of raised intracranial tension,
Yes,
and prevention of some complications like hyponatremia, other
Yes.
things also has to be taken care of. Okay. So I think for undergraduate level, that should be fine. So this is how you, so most important thing is history itself. You saw that in CNS, if you have a acute onset duration progression defined, try to localize the lesion, cortical, subcortical, brainstem for a hemiplegia, try to localize the vascular territory if at all you are thinking of a vascular event. Then all the set of negative histories to substantiate this and rule out other conditions. Past history, again, you have taken comprehensively. Examination, of course, we discussed. I think that was a very good case presentation.
Thank you, sir.
Thank you, sir, and thank you
Thank
for
you.
taking the time to come today for the meeting. It was truly
Yes.
educational. And thank you, Swati, for presenting the case so smoothly. If anyone has any doubts, they can put it up in the comment section or ask sir directly.
Of course, CNS we can take for hours together, but I wanted to restrict it for 1 hour, 15 minutes. So this is what they will ask you in the examination, especially undergraduate examination, they may not go in details. Vascular territory, as simplified, it is not like that, to be frank. You have a stem, you have a perforating branch, you have a branch. Weakness differs in each of those, Percheron artery. Don't worry about that now. But as of now, try to localize the lesion as cortical, subcortical, brainstem, vascular territory, MCA, ACA, PCA. Risk factors, very important for stroke management. Complications. and examination, UMN versus LMN differentiation. How you examine, of course, again, that is something you have to practice at bedside, and diagnosis, writing a diagnosis. That should be enough. Thank you, sir. Susan, sir.
Krupa?
Thank you so much, sir.
Krupa, are you there? Krupa? Chinivalar, sir? Chinivalar?
So Krupa is not here.
Okay.
Is there anything?
Down from the students?
No, sir, not as yet.
sir, Billa sir.
John?
Yes, sir.
Chinivalar, idhara?
Illa, sir. Sir, illa.
Okay, let it be. Yeah, shall we call it a day? Hampi?
Yes, sir.
Yeah, you can conclude.
Thank you, everybody. Thank you for joining us. And once again, thank you, sir. Thank you, Swati, for attending today's meeting with us.
Yeah. On behalf of IMA Karnataka State Branch, I immensely thank Dr. Vishwanath. Probably, if I would have been an UG now, I would have failed.
Thank you. No, sir.
So much of things to learn from the teachers, and so much of depth of knowledge we need to acquire. That is
just
yeah, out of the day. And definitely, the students across Karnataka are fortunate to have so much of immense guidance from a teacher like you. Definitely, we are the students, and I went back to my days of medicine. Yeah, because of these complications, I chose surgery as my profession. I'm a surgeon.
Thank you, sir. Thank you so much.
Medicine, definitely, teachers like you will make the students to love medicine as a subject, and they practice in future. Definitely, we are fortunate to have you, sir, on our virtual platform. This is an initiation across, first time in India that we have taken an initiation like exposing the students to such a brilliant teachers across Karnataka, so that their anxiety, the presentation will go very in a right direction. And today's presenter, I feel she has done excellently well.
Excellent. Yes, very good presentation.
Yeah, that was very good presentation, and your guidance and your ನಿಮ್ಮ ಮಾರ್ಗದರ್ಶನ ತುಂಬಾ ಚೆನ್ನಾಗಿತ್ತು ಸರ್. ಧನ್ಯವಾದಗಳು ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪರವಾಗಿ. ಮತ್ತೊಮ್ಮೆ ತಮ್ಮ ಸೇವೆಯನ್ನ ನಾವು ಬಳಸ್ಕೊಳ್ಳೋದಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀವಿ ಅಂತ ಹೇಳ್ತಾ ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
There's a question from one of the students. They're asking to tell more about the migraine.
Migraine?
Yeah. So anyway, I didn't want to talk. This one of the rare causes of hemiplegia. So I didn't want to touch, because if we tell probably when we ask students cause of hemiplegia, the rarest cause will come. So don't worry as a migraine as a cause for hemiplegia. There is an entity called migraine hemiplegia, which is extremely rare. So whenever you have a hemiplegia patient, that is the last thing you would think of. First thing is vascular stroke only. So probably you think. With respect to hemiplegia, that's what I'm telling. But per se about hemiplegia, migraine, it's again a different, totally a different discussion. So with respect to hemiplegia, they're asking, yes, very rare. And
yeah, for the UGs, probably the way of presentation, how they take the case, the history taking, the examination,
that's all is important.
And basic questions and answers, and they will be. I think that is the motto of our teaching the platform. Probably students should take home the message that they need to present the case in a methodical way. They need not have to worry about the rarest of rare cases. Basic, you need to know the basic answers. They have to answer. Thank you very much, sir. Thank you on behalf of IMA Karnataka.
Thank you very much.
We have a presentation next week on 11th on obstetrics and gynecology. I request all the students to be again and pass on this message to all the students across Karnataka. Thank you very much, sir.
Thank you.
Bye.
Thank you, sir. Thank you so much.
Thank you very much, sir.
Yeah.